Shilpi, are you sharing the slide? Thanks.
Ma'am, I have shared the slide. Hopefully it's visible.
Yes, we can see. Rashmi?
Yes, I can see.
Yeah, you can start. I think we are on time.
Just give me a cue when to start, now or?
Yeah, you can start. Dr. Rashmi, you can start.
Good afternoon, everyone. On behalf of the Indian Childhood Cancer Initiative, ICCI, it's my great pleasure to welcome you to this important webinar on developing a roadmap for childhood cancer service delivery in India. I am Dr. Rashmi Palashiri. I'm a pediatric hematologist and oncologist working as an associate professor in Ramaya Medical College in Bangalore. I am also the co-chair for a task force in ICCI involved in information awareness and engagement of patient caregivers and community. As we observe the International Childhood Cancer Day, or ICCD, on February 15th, it's important to recognize its significance. ICCD is a global campaign dedicated to raising awareness about childhood cancer and its unique challenges. This day also underscores the importance of community participation and its unique challenges. This day also underscores the involvement of organizations like SIOP, which is the International Society of Pediatric Oncology, and Childhood Cancer International, aiming to create a world where childhood cancer patients, cancer survivors, and their families receive care, treatment, and all the support they need. The framework of ICCD's 2024 to 2026 campaign ensures that every region, irrespective of what part of the world they are in, can tailor the campaign to local needs, fostering dynamic and sustainable progress in childhood cancer care. Now, a few words about ICCI, the Indian Childhood Cancer Initiative. ICCI was launched in March of 2023 as a national multi-stakeholder effort to enhance childhood cancer care in India. We collaborate with India's pediatric oncology community, various global partners like St. Jude's Global, the Government of India, WHO Southeast Asian Region, SEAR, and other civil society organizations to strengthen pediatric oncology services and drive sustainable impact. The organization hopes to play a crucial role in advocacy, research, and capacity building efforts, strengthening the pediatric oncology landscape. Today's discussion is a crucial step in strengthening our efforts to improve pediatric cancer care in India. We are privileged to have a distinguished lineup of speakers and panelists today. I'll start with our first speaker, who is Dr. Bishnu Giri, Technical Officer, Cancer Control, WHO Southeast Asia region, who will discuss global and regional efforts of WHO on childhood cancer. Dr. Ramandeep Arora, Consultant Pediatric Oncologist, Max Super Specialty Hospital. Mr. Chandan Kumar, Senior Project Manager, Resonance, Group Leader, KidsCan Connect. And our panel discussion will be moderated by two eminent moderators, Ms. Poonam Bagai, Founder and Chairperson of KidsCan, and Ms. Aparna Mittal, Founder and CEO of Patients Engage. Our panelists will be Dr. Shweta Singh from National NCD Management and Surveillance Office, WHO India, Dr. Manas Kalra, Honorary Secretary of the Pediatric Hematology Oncology Indian Association of Pediatrics Chapter, Mr. Nitai Gaura Panigrahi, who is the founder of Umide Odisha, a civil society, Ms. Sonal Sharma, co-founder and board member of CanKids KidsCan, who's also the mother of a survivor, Mr. Sandeep Kumar, founder and CEO of Digi Swasthya Foundation, who himself is a survivor, and Ms. Shivani Chauhan, who's a senior program manager at ICCI. We warmly invite our audience to actively participate, ask questions, and engage in this meaningful discussion. Together, we can make a difference in childhood cancer care. We are honored to have representatives from the Government of India, WHO, civil society, childhood cancer survivors, and parents joining us today to share insights and strategize on enhancing childhood cancer care services across the country. Unfortunately, Dr. L. Swasicharan, Additional Deputy Director General, Director General of Health Services, Ministry of Health and Family Welfare, and Dr. Shikha Vardhan, Assistant Director General, Director General of Health Services, MOHFW, will not be able to join us today due to some last-minute commitments, but we appreciate their support and contributions to this cause. Before we begin, a few housekeeping rules. Kindly keep your microphones muted when not speaking to avoid background noise. Feel free to use the chat box to ask your questions and we will address them during the panel discussion. And the session is going to be recorded for future references. Our first speaker is Dr. Bishnu, Technical Officer Cancer Control, WHO SEAR, who will share global and regional efforts of WHO on cancer, childhood cancer. Dr. Bishnu, please take stage. Thank you.
Just a quick one to everybody in the audience. You can put your questions in the Q&A. You will see the Q&A tab at the bottom, option in the bottom. You will not see the chat option.
Thank you very much, Dr. Rashmi. Can I share my slides? I hope the slides are visible. Yeah. Good afternoon, everyone. Thank you very much for letting us this opportunity to be interacting with you once again. It's always good to be being in this group of leaders on various fronts of childhood cancer continuum in India and beyond. Specifically, I'm saying beyond because we have been leveraging the capacity that this group has in supporting the other countries in the Southeast Asia region. Some of that which I will also be taking the names later while I am speaking. I have been asked to speak on WHO's global and regional efforts in childhood cancer. I will be speaking very less on the global efforts because they all are there on the web and all of us are aware of what the headquarters is doing. I'll be focusing more on the regional efforts. And I understand that my colleague, Dr. Sweta from WHO Country Office India will be speaking more on the more in the context of India. This picture, I hope it is visible well. This picture is of a child who is being treated for retinoblastoma in Myanmar. The pictures are credited Dr. A.A. Khaing from Yangon Children's Hospital. On the global efforts, I'd just like to touch on 3 points. First one, as we all know, after the launch of the Global Initiative for Childhood Cancer by the WHO headquarters, the Cure-All framework has come up. And this is the landmark document which guides all our efforts on childhood cancer globally. And the 4 pillars that has been identified, as we all know, centers of excellences and care networks, universal health coverage that addresses the issue of availability, access, and equity, and regimens for management along with quality assured drug access, and childhood cancer information management leading to evaluation and monitoring. And there are certain enablers identified: advocacy, leveraging of the financing mechanisms, and linking the government policies. So these are our framework which guide all our activities on childhood cancer. On the right hand side, I have kept 2 pictures which highlight the focus or the direction that the headquarters is, the WHO headquarters is guiding the world towards. On the top is a recent initiative, the Global Platform for Access to Childhood Cancer Medicines. So this is an ambitious initiative through which the WHO, St. Jude, UNICEF, PAHO, and other partners are aiming to collaborate to make childhood cancer medicines, quality assured childhood cancer medicines, available to children across the world. And for the low income countries, it is hoped that these medicines would be provided free of cost. And there may be heavy subsidies on middle income countries. This has been, the pilot phase has started, and there are 12 countries which have been identified to participate in this initiative. From our region, Sri Lanka and Nepal have been identified to participate. And through the learnings of this initial pilot, many more countries will be included gradually, and it is hoped that by 2030, at least 50 countries would be joining the platform. The picture on the right-hand side bottom is that of the president of Peru, who is showing a legislation that guarantees treatment, diagnosis and treatment for childhood cancer. This is one of the iconic and first in the world where childhood cancer care has been guaranteed by a law enacted by the parliament. Through this, it shows how universal health coverage is being promoted for childhood cancer. And many countries have followed the suit. And in our region, many countries are already providing childhood cancer care free of cost. And for those countries that were not initially doing, they have started including stepwise various components or certain proportion coverage for childhood cancer care. Recently in Nepal, the government has declared that the treatment would be provided free of cost in the government facilities across the country. In the Southeast Asia region, we have 11 countries, including India. And as per the Globocan estimates, for the year of 2022, there were 56,000 new cases of childhood cancer. And we all understand that there are many cases which remain undiagnosed. Some of the estimates showing that the proportion of undiagnosed cases could be up to 49% in some countries and places. But this is the most authoritative data we have, 56,000 estimated cases in 1 year, new cases in 1 year. And the mortality to incidence ratio is 0.46, which is almost 3 times compared to the high income countries, meaning that in our region, the number of deaths, the deaths of children because of cancer is at least 3 times higher than the high income countries. From regional office, we are taking some initiatives to address this gap. First area is on the aspects of policy. So while the national policies on cancer are being developed, or when any other relevant policies are being drafted, we encourage countries to incorporate childhood and adolescent cancers into those policies. This picture is of the impact review of Nepal that was done in 2021. This was the first of its kind where childhood cancer was a focus. You can see in the title itself that it was an impact mission, which assesses the country's situation of cancer care and provides the tailored recommendations which are contextual to that country and which are feasible and implementable with a timeline, and the partners who could help in implementing those recommendations. So this is carried out in a year. About 10 to 12 countries go through this process, invite for impact review. And when Nepal had invited for impact mission, the mission focused on childhood cancer. And Nepal is one of the focus countries for the GICC, and that helped having a childhood cancer as a focus of this impact assessment. And last year, Nepal formulated its National Cancer Control Strategy. And the government of Nepal has incorporated most of the recommendations from the impact review mission. Last year, Indonesia also drafted the National Cancer Plan for the 10 years. And with the involvement of WHO, St. Jude, and other partners, the childhood cancer components have been addressed very effectively, very efficiently within this strategic plan. And parallelly, we are also working on a standalone childhood cancer policy for Indonesia, which is expected to be finalized very soon. That will provide more details, and the structure and alignment is very well established because both the plans were developed together. The national plan has already been launched, National Cancer Plan, whereas the Childhood Cancer Plan is in the final stages. So this is how we are advocating and encouraging countries to incorporate childhood cancer into their national plans. Just to giving a few examples. Sri Lanka was one of the pioneers which developed its standalone childhood cancer policy way back in 2021. In 2022, we worked together with the government of Maldives for developing the national cancer plan, and childhood cancer has been addressed specifically with due focus in this plan as well. And similarly, in Myanmar, even though the political situation was not very conducive for collaboration, we have worked with the team there to include childhood cancer into the National Cancer Plan. As we all, many of us are aware that one of the notable initiatives from the region is the establishment of the Southeast Asia Regional Childhood Cancer Network. It was established in 2020 with the aim of promoting, fostering collaboration between institutions that are providing childhood cancer care and leveraging on the strength of one institution to build capacity in another. That was the whole idea behind this network. In 2023, so as of now, there are 20 institutions that have been nominated by the Ministry of Health to participate in the network. Beyond that, many other institutes participate in the activities on ad hoc basis. They are invited or as an associate member, including CanKids also. So we have about 40 institutions that are hospitals and other institutions which are regularly participating in the activities. In 2023, these 20 institutions, which are official members, provided care to more than 7,500 new cases of childhood cancer. Just giving in some of the snapshots of activities carried out under the umbrella of CRCCN. We have our one of our member institution is Tata Memorial Hospital that coordinates many of the activities of the network. One of the activities that has sustained for very long and been very effective is the virtual tumor boards. This virtual tumor board is convenes once every month, and till September last year, 34 sessions had been carried out. Till now, 35 institutions from 8 countries have participated in various sessions. On an average, there would be about 6 institutions in every virtual tumor board meeting, and 4 countries represented, and an average of 3.6 cases being discussed. This is just one snapshot of the virtual tumor board in progress. We have also started a pathology external quality assurance services, again coordinated by Tata Memorial Hospital, Mumbai, in which the aim is to build the capacity of our colleagues in a relatively less resource setting, pathology colleagues, in making diagnosis of childhood cancer. And this is carried out completely through virtual means, and all the colleagues in the peripheral center need is a good access to internet. So far, 4 cycles have been carried out, and 18 institutions have participated from 9 countries. And out of these 18 institutions, 8 are not member of CRCCN. So CRCCN, although it started its activity with the ministry nominated members, participation is growing, and it's very flexible. The CRCCN does not restrict participation on the event on the network activities. Specifically, if they come through one of the members, it's actually officialized also. In the fronts of capacity building, we are working with AIIMS New Delhi, and AIIMS New Delhi is leading the development of training modules on common procedures in pediatric oncology. That includes bone marrow aspiration, lumbar puncture, pediatric pain-free procedures, and care of central lines, etc. And with Mumbai, Tata Memorial Hospital, Mumbai, we have carried out training, virtual training of nurses working in pediatric oncology units. And this was one of the visits in one of the centers which is not a member of CRCCN. And at that time, while the hospital services were being discussed about, we could see that the virtual training being provided through CRCCN, through Tata Memorial Hospital, had been very useful for the newly established cancer center. This is from Nepal. Another activity that we are focusing on is establishing shared care center networks. So shared care center networks, the idea is to take the part of the treatment of childhood cancer closer to the patient's home in portions that are that could be taken closer to the patient's home. The intensive phases of the treatment are generally carried out in comprehensive cancer centers or the principal treatment center, whereas the easier and the maintenance phases are taken to hospitals with pediatric inpatient facilities that are closer to the patient's home, thus reducing burden of treatment on the families. That is the idea, and this started from Myanmar in 2019. And initially, there were few institutes that were identified, and patients were referred for. Once the treatment had started, some of the care was cascaded down to the nearby centers, and this was seen to be very effective. And following this, it has been formally started in Nepal, and there are 6 shared care centers operated by one principal treatment center, and this is growing now. And in Myanmar, currently, the number of shared care centers is growing so much. Growing very well. There are 41 shared care centers operated by 2 principal treatment centers, and we have the data which shows that 32% of the patients, newly diagnosed cases, are taking treatment from the shared care centers, part of their treatment from the shared care center. So it is being taken up very well, and it is effective. These are the snapshots from Myanmar and from Nepal of the shared care center operating. This idea, we have also proposed cross-country shared care center specifically for those countries with relatively smaller population, very less number of childhood cancer cases, which may not have the capacity to treat on their own. And we are proposing to link up institutions in those resource limited countries with bigger institutions in the neighboring countries. This is a training booklet which is in Bahasa Indonesia. This was developed by Cipto Mangunkusumo Hospital specifically for training the colleagues in Timor-Leste on management of childhood cancer with the aim of establishing shared care. The screenshot that we see from YouTube channel is the training session conducted by Cipto Hospital and participated by HNGB colleagues. It is still there in YouTube. It is still available. This is one activity we took up as a network, and many of the members who contributed to developing this book that is being displayed on the left-hand side now are probably on the call now. In this one, we had more than 50 colleagues from CRCCN member institutions who contributed to developing resource guides. So these resource guides are very handy tools. It can be poster, or it can be a small written contents, small book which can be kept on the in the table nearby the procedure room or nearby the OPD clinic. Handy tools for the shared care centers, because in shared care centers we assume that full expertise is not available, and the colleagues there may need to refer to certain specific information quickly whenever there is where they are planning to manage a child with cancer. So this picture on the left hand side is a medication information sheet. It is in the form of a book, which provides very quick reference to the medicines commonly used in shared care center. Apart from that, we have developed posters and job aids on 6 priority topics which were identified by the shared care center colleagues that they need. For example, managing extravasation. So the poster would be pasted on the wall in the procedure room, and whenever there is extravasation, the colleague would quickly have a look for a reference. And similarly, there are many other 6 topics for which these job aids have been developed, and this was developed as CRCCN network with more than 50 colleagues from the network, 8 institutions participating in developing of this. This is in the final stage of designing, and as soon as the designing is complete, we'll be sharing it publicly. This was not the initial plan, but it emerged as the network CRCCN started functioning. There are horizontal collaborations that have emerged, and they are self-sustaining in their nature as it appears now. For example, Yangon Children's Hospital and Kanti Children's Hospital, Myanmar and Nepal. So they are exchanging information, their experiences. Yangon had supported Kanti when Kanti was initiating the shared care network. And now Kanti is supporting Yangon when colleagues in Myanmar are initiating their work on standardizing the treatment regimens and having a nationally agreed regimen. So they're sharing experiences and sharing tips and what works, what doesn't work. So it's a very beautiful kind of collaboration emerging out of there, no cost involved. And another collaboration is partly supported by us, or partly encouraged by us, is between GGW National Referral Hospital in Bhutan and Tata Medical Center in Kolkata. Because of the geographic proximity, the patients are already being managed from Bhutan, are already being managed in Kolkata. We want to formalize this and make it more structured as a capacity building approach, as a cross-country shared care network. If Dr. Arpita is on the network, she might be able to add further, and she has started the team of Tata Medical Center Kolkata have already started working on developing this this collaborative relationship. Similarly, between Tata Memorial Hospital and Kanti Children's Hospital, it started with the CRCCN network activities, and now there are so much of exchanges that even we are not aware of, and formal fellowships, a lot of information exchanges, tumor board support, case consultation, many things are ongoing, which now we are not able to track also. So this has emerged out of the network activities. And SIPTO Mangum Kusuma and HNGV, this has initiated, and formal sharing of patient or the patient care. It's taking a bit of a time because of certain administrative formalities that have to be completed, but we are still making progress there. Another area of focus that we are having is having regimens, developing regimens and quality improvement works. I'm taking 2 snapshots. One is from Sri Lanka, where we worked on having a guidelines for fever and suspected or confirmed neutropenia in children. Another example is development of Wilms tumor management guidelines, which is being developed as a national guideline. I mean, every institution are having their own guidelines, but having a nationally agreed single guidelines is of a lot of value, and we are attempting to have it there. And this has been submitted to Ministry for endorsement. That's why the page looks a bit blank now. In cancer registry, Sri Lanka has published one dedicated childhood cancer registry report, and they are expanding the childhood cancer registry to population base in certain parts of Sri Lanka. That's exemplary work being done. In Nepal and Myanmar, the SBCR, hospital-based cancer registry for children, is being strengthened, specifically in collaboration with St. Jude, and they're using the platform from St. Jude's SJ Cares. The ministry has given clearance, and the SOPs have been laid out on use of those platforms for registry. India, I have kept with separately isolated because we hear very good news from Chennai on the works being done by Dr. Venkat and his team, and we are very excitedly waiting to learn from this initiative and use the lessons and the expertise that have come out of there for supporting other countries in the region. That's all, some of the highlights of the work that we are currently focusing on, and I'll be happy to have any questions or clarifications if there are any. Once again, thank you very much for letting us share some of our works.
Thank you so much, Dr. Bishnu, for sharing WHO's efforts towards childhood cancer care in all of Southeast Asia and specifically focusing on India. If that's okay with you, we can actually take the questions at a later time, maybe closer to the panel discussion or during the panel discussion. So without much delay, I would like to have Dr. Ramandeep Arora, consultant pediatric oncologist, who will discuss the stakeholders' efforts in India, the ICCI, or the Indian Childhood Cancer Initiative. Dr. Raman, over to you. Thank you.
Thank you. I hope you can hear me.
Yes, we can.
Okay, and you can see my slides.
Yes.
Yeah, so thank you so much. And it was wonderful to hear the work being done in the Southeast Asian region. And I'm going to talk about stakeholder efforts in India and also about the Indian Childhood Cancer Initiative. I'm based in Delhi as a pediatric oncologist, and I also work within the ICCI. As Dr. Bishnu has given us a sense of how the work has been evolving in WHO, before or other than WHO, there are several stakeholders in childhood cancer care. And broadly, they can be divided into three parts: the pediatric oncology community, which includes all healthcare providers, the civil society community, which provides social support, and of course, the government of India. And I've just put some milestones in the journey of each stakeholder. And so in the case of government, establishment of Tata Memorial Hospital in 1987 is a huge landmark. The start of the National Cancer Control Plan, which included establishing regional cancer centers, around 20 odd of them across the country, was huge. You know, we have some very well-established regional cancer centers. The National Cancer Registry Program, initiated by ICMR, which today is the flagship program for cancer registry, is another one. And the National Cancer Grid, which is not strictly governmental, but it is quasi-governmental because it's through Department of Atomic Agency, Tata Trust, and Tata Hospital. And so these have been the initiatives which have come through the government, and they keep coming, but they are often in the context of non-communicable diseases rather than cancer per se. And what I also want to point out over here is that none of these is specific to childhood cancer. Now, however, the initiatives taken by the pediatric oncology community, not surprisingly, are all focused on childhood cancer. And I've put some key initiatives over here, right from the launch of the first pediatric oncology unit in the country, which is at Cancer Institute Adyar, the launch of the MCP 841 protocol, which is recognized as the first collaborative research study in India for childhood cancer, PHO-IEP, which now is a few decades old. Then PHO-IEP starts holding the FOCON workshops and the NTPPO workshops. We've hosted a few PSYOPs. So PSYOP Asia in 2002, PSYOP Mumbai, which was a landmark for us in 2007, starting with the fellowships in the country. Then later DM fellowships in 2009, building up the workforce. The INPOG, or the Indian Pediatric Oncology Group, now called the Indian Pediatric Hematology Oncology Group, has been active since 2015. And very recently, we had PSYOP Asia Mumbai in 2020-21. So these have been the work being done by the pediatric oncology community. Finally, the civil society, which obviously started from being focused only on or focused on all kinds of cancer, really took a boost, I think, with two initiatives. One was the arrival of CanKids, which was the forerunner of what today is a bouquet of wonderful NGOs working across the countries. across the country. So Can Kids first under Indian Cancer Society and subsequently independently really set the ball rolling and gave a very important support to all clinicians across the country. And they were partnered and complemented very nicely with the Jivdaya Foundation and the Indian Pediatric Oncology Initiative. And in the first decade of this century and the second decade, I think that was a transformative change for where we are today. And along part of that was this FOSCON meeting, which many of you would have attended, which has started in 2016 in Mumbai with what was the first one. So this has been the traditional stakeholders who have a stake in how childhood cancer is taken care of in our country. But the challenge is that there is no formal agreement, no formal MOU between organization, these stakeholders. The intersection can be ad hoc. So once in a while it's done. It can be informal. There's an understanding. We'll help you. You'll take help from us, but without really having a formal understanding. And because of that, it is not necessarily condensed into a strategic plan with medium to long-term objectives. And so as a result of that, although a lot of work is being done, there is no roadmap of where to go and no metrics to measure whether you have achieved that roadmap and where the gaps lie. Although individual institutions or organizations may have made that effort, it has not happened at a pan-India scale. And within this environment, the launch of the WHO GICC in 2018, preceded by the mandate from the World Health Assembly to recognize childhood cancer as a public health priority, was a milestone. And that, I think, partnered with St. Jude's Global or St. Jude's Children's Research Hospital as a WHO partner, really set the ball rolling. And so now in this system of having these traditional stakeholders, you suddenly had a catalyst. And the catalyst, what it has done is it has allowed people, and as Dr. Bishnu has shown, Nepal and Indonesia and Myanmar and so on, Sri Lanka, to do what we would like to do, which is all these stakeholders can now formalize the intersection and have a more clear strategy and a goal. And you can use many terms for it. Roadmap is one word, policy is another word, plan is a third word. But the idea basically is that all these people together can have a more formal plan going forward. And that is the idea of Indian Childhood Cancer Initiative. So the Indian Childhood Cancer Initiative, which, as Rashmi mentioned at the beginning, was launched in 2023, was launched with the purpose of being a multi-partner initiative, which wants to strengthen the Government of India's program for pediatric cancer control. And I've showed you what the Government of India had been doing before on cancer and pediatric cancer control, with the WHO goal of at least 60% survival across the country by 2030, and also trying to achieve 100% access. The framework which you want to use is the WHO GICC Cure-All Technical Package. And again, this is something which Dr. Bishnu showed in his slides. And the hope is that by bringing everybody together and by working with the government, we can convince them, as was pointed out in the Rajya Sabha report, and I'll share that with you as well, to develop a national childhood cancer comprehensive management policy, which goes across the cancer continuum. So with these goals, this is the launch in 2023 of in Delhi of ICCI. And we see ICCI in three main roles, and I've clubbed the first two roles together. So stakeholder engagement and central and state government engagement is very critical to what we are doing. So WHO, India is a stakeholder, WHO CRCCN is another stakeholder, government is another stakeholder. And so when we look at the coalition of stakeholders for childhood cancers, and we can make certain broad divisions, we've got some professional societies, PHOIP, which is represented here, Dr. Manas is here, National Cancer Grid, which is well known, and the Indian Pediatric Hematology Oncology Group are the three main organizations in this space who are focusing on childhood cancer. Besides that, we have got, starting with Can Kids, but now a huge number of regional and national and local not-for-profits, civil society organizations, who are really leading the way and collaborating with all other stakeholders. We then have international societies and technical partners, and you've heard WHO-CR. We've got Dr. Shweta from WHO India. SIOP and CCI is well known to you, as is St. Jude's Global. We then have, of course, the big community of the hospitals and representatives from hospitals. And today in ICCI, we have people from more than 70 hospitals who are volunteering their time. And of course, nothing is complete without the government. So the central government and the state governments are so crucial and important here. And along with that, quasi-governmental organizations like NCDI and CRP, ICMR, and so on. So this essentially is the coalition from which any cohesive policy, program, plan will emerge. And the idea is, how do we bring them all together? So one of ICCI's role is to bring them all together as much as possible. And we've had some success with it. And today's meeting is an example of how we can get the government, the WHO India, the WHO-CR, the not-for-profits, the parent, the survivor, the professional associations. It's another way of bringing all these people together. So today, ICCI has 265 volunteers, people like you who are giving their time and expertise and effort, and you represent more than 20 civil society organizations and more than 70 hospitals. So thank you so much for your effort and interest, and more are always welcome. And I'll leave an email at the end of this presentation where you can write and connect, or you can drop a message in the chat and we'll get back to you. But also in the way we are structuring ICCI at the governance level, we are trying to make sure it is truly multi-stakeholder. And so you will see the 3 professional societies I mentioned, and we've got representatives from there. You can see the 3 kind of hospitals we have: public sector hospitals, private hospitals, trust hospitals, as well as different not-for-profit organizations which are there. These are 3 of the few others we have. And then, of course, making sure we have the parent voice, the survivor voice, as well as the nursing voice. So this is one. Now, along with this, we were very encouraged to see the Government of India working on the situational analysis. And you must have seen this document, which concluded that the need of the hour is to formulate a childhood cancer policy. At the same time, 2-3 years ago, the Rajya Sabha Parliament, as endorsed later by the Lok Sabha Parliament, talked about developing a national childhood cancer management policy. So we know as a stakeholder, the government is interested. The only problem is it is not intersecting with our interest right now. We are not intersecting. So the goal is, it is intersecting with our interests, but we are not intersecting as we work together. So the goal is to work together on this and complement each other. So ICCI's work has been to engage with the Health Secretary, Mr. Sudhansh Pant, Dr. Shikha Vardhan and Dr. Swasti Charan, who could not be here today and send their apologies for a last-minute meeting, who were very much there in 2023 for another meeting we had organized in Delhi. We've had engagement with the nursing lead in the ministry, and something which is coming hopefully in the near future is the NPNCD, National Program for Non-Communicable Diseases, children's document, which for the first time will have childhood cancer in it in any governmental document. So we know that there is engagement. We just have to try and keep this ongoing and keep amplifying it. Along with that, there's a huge amount of work going on in the states, and I think this has really been led by CanKids. So a lot of MOUs been signed, 8 to my knowledge last time, but I think I keep hearing of more and more efforts going on. And so they are working with the state governments to try and connect with them, because we know health is a state policy, so you can work in parallel with the health, with the central and state government. So what are the activities? And I'll take the last 5 minutes to close this. We've got 11 task forces and we've got 70, 80 odd projects going on right now. Here are the task force chairs. I'm not going to go through each of the 11 task forces, but each task force is generally led by a healthcare provider and a social care provider. And together they complement each other, and they are looking at areas which are critical to developing any plan for childhood cancer. So I'm just going to take 3 examples and try to show what has been happening. And these are just one slide each. So one of our goals is to strengthen pediatric oncology nursing in India. And as you will see from the input, there are many stakeholders involved over here. We've had big meetings, smaller meetings, and whatever is in blue is in the pipeline. It hasn't happened yet. So as you can see, after the 2024 meetings, and you can see the picture below, we've had many people engage. We've had ministry representation. We've had some SOPs of the core body being agreed. And we are now drafting a proposal to look at the baseline standards of nursing care in India. In fact, that proposal has been drafted. We're going to launch the study. So the outcome of all this is going to be that there will be a formal nursing body registered in the near future, and there will be a study which will actually document current standards of pediatric oncology nursing in India. Hopefully, the impact will be, and I've just listed a few, and I'm sure there can be more, that it will lead to hiring of more staff, better standards of training, etc., etc. So this is an example of how one task force in ICCI, by doing multi-stakeholder work, is driving change. Another example, which Dr. Bishnu mentioned towards the end of his talk, is this cancer registry, which, as many of you will know, only happened, I think, a week or so ago. And over here, the idea is that there's been no dedicated childhood cancer work in the registry space, although ICMR, NCDIR, and CRP has a long track record. So there was a desire to develop population-based childhood cancer registries and hospital-based childhood cancer registries. Again, several stakeholders involved, national and international. A lot of activities had been done, from creating the core form, which you can see, to creating a server or having a couple of servers on the red cap. And one of the servers over here, which is a backup server, is there, which you can see. Hiring and training of staff. We had a great workshop meeting a week ago in Chennai, and that led to 27 centers from Chennai contributing to the first PBCCR report. It's written wrongly there. It's not HBCCR report. It's the PBCCR report, which was released by the Health Minister of Tamil Nadu and the Health Secretary of Tamil Nadu. And again, the front page of the report is also seen. Now, that can, of course, have an impact in some of the things we do subsequently. And there's now a proposal to extend this registry from just Chennai state to the entire Tamil Nadu state. The final project I want to show you, or the program I want to show you, is developing psychosocial standards for children with cancer in India, work being led by the Psychosocial Task Force, along with some other international experts, and many people and organizations in the social sector and the psychological sector. We had a wonderful 2-day meeting 6 months ago. Subgroups have been formed, subsequent meetings are happening, and we are learning from the PAHO document, which you see on the left-hand side. So priority areas have been identified, the structure and scope has been defined, and the idea is in the coming 6 to 12 months, we complete these psychosocial standards, and the outcome would be, desired outcome would be that these are adopted and these are implemented. So I think I'm running out of time, so I will whiz through this. On the back end, we've got 11 task forces, but on the front end, we are working at these 5 main blocks, because this is how government aligns with the dimensions of health. And so each of these are projects, and some projects which are in solid are completed. Some projects which are in white are ongoing, and just shows you the range of work which is going on in ICCI. And you're all very welcome to be part of it in a small or large way. I would like to end my talk and thank the organizers for this opportunity to present and showcase ICCI, and happy to answer questions if time permits. The website address and the contact details are below. Thank you.
Thank you very much, Dr. Raman, for shedding light on the ICCI and its work so far. The questions, again, like I said, we can move it towards the part of the panel discussion. Lastly, we have Mr. Chandan Kumar, Senior Project Manager, Resonance, Group Leader, KidScan, who will speak on the value of meaningful involvement of persons with lived experience. Mr. Chandan, please proceed.
Chandan, we can't hear you. think you're speaking. No.
Can you hear me now?
Yes, we can.
Yeah, okay. So I said thank you everyone for giving me opportunity to speak about this value of meaningful involvement of person with lived experience. And this is very, very close to my heart. And I have been advocating for this since 2006 when I was getting a treatment at AIMS for ALL. So yeah, so let's start with the topics. Why I'll touch upon these four things in this whole presentation. Why this meaningful involvement is important, and how this can impact overall service delivery model in India. So yeah. So first, let me introduce myself. Who I am. So I'm a childhood cancer survivor and the patient advocate, and the co-chair of ICCI Survivorship Task Force, a group leader of Kids Can Connect, India is one of the largest childhood cancer survivor group, and one of the founding member of this group, the board member of CanKids, the India's largest organization for childhood cancer. I have led India's largest signature campaign to make childhood cancer child health priority in India for around 4 or 5 years. And professionally, I am working with the Rajini's Health as a senior project manager. And I'm proud husband of a survivor and a 1-year-old daughter. So this is all about me. And a recent thing, like I have prepared this presentation and then I got a feedback that the meaningful involvement cannot be a faceless. And that's why I have put my picture here. And I realized the importance of being an advocate, a vocal advocate. So yeah. So what is the lived experience, and why this is so important? So as per the WHO framework, the definition is like what someone has experienced themselves, especially when it gives the individual knowledge or understanding that people who have only heard or learned about such experiences do not have. So basically, from the policymaker perspective, or someone from the clinician, someone from who are at the top level, can have a different view about certain things. But from patient perspective, and who are going through the such experiences at the ground level, can have a different experiences, right? So yes, government or the social government can draft a policy, or policymaker can draft a policy for certain things, but actual experiences can be a different at the ground level. So let's take an example of certain a big hospital. You have to, if you want to take an appointment at certain level, then you have to spend whole day in a queue, or maybe sometimes you have to stay at the footpath to get the next morning appointments. All these things are not a patient centric, right? So sometimes you need to get a feedback from the people who have lived that experiences, and you need to take a feedback that how we can improve on this, right? So this is a very, very important aspect which needs to be covered. And let me share one recent example, maybe 3-4 years back. And this creates a lot of wrong messages on the ground. So let me give you my example. So I belong from a small town from Bihar, right? And when I got diagnosed with cancer, everyone in my village was scared that I will not survive. And even some of my family members told my father that I will not survive. So why they are wasting time and money on me? But my parents fought, we fought, and I survived. And then the message went to my village that childhood cancer is curable, right? After 3-4 years back, a small child diagnosed with the ALL, they contacted me. I called them to AIMS Delhi, and they get a treatment, but somehow the child did not get survive, right? But the experience they have received here through the social support team of CanKids, from the doctors and everyone, even till now, they are sad about that the child did not get survive. But the experience they have received, the kind of support they have received in the hospital, that they are overwhelmed with that. Even they every time they meet me, they kind of show gratitude that you have supported me a lot. That was my fortune that my child did not survive. But that's how the messagings keep going on the ground. When you treat people with the kindness, when you treat people with the gratitude, that even the child did not get survived, but the messages go on the ground is a different, right? So that is why it is very, very important to involve the person who had lived that experience in the overall service delivery, overall policy making, right? And what is the meaningful involvement? That is the another aspect I wanted to cover here, right? Sometimes I've seen, because I'm working in this space for many years. Sometimes I've seen that for a sake, people involve the survivors or parents and the person with the lived experiences, but they are not empowered enough to voice their voice, right? They are not empowered enough to raise their voice and give some kind of opinion, but they are just part of that part of the service delivery or the policy making or the decision making, but they are not their voice is not getting valued, right? So according to, again, the WHO framework, the respectful, dignified, and equitable inclusion of individual with the lived experiences in range of processes and activities within an enabling environment where power is transferred to the people, valuing their lived experiences as a form of expertise and applying it to improve health outcome. So this definition is very, very important, right? I may not have a technical expertise, but I have a practical expertise. I have seen I have been through this journey, and many people have been through this journey, right? So I may not have a technical expertise, so I won't be able to use a medical jargons in my voice when I talk about something. But in a simple layman languages, I can point out that this decision making or this policy making should happen in this way to make it more patient centric, right? And this is what according to me, the meaningful involvement is, right? And again, the why meaningful involvement is important. I have given you some of the example, but in this slide, I'll take you to the exact kind of WHO framework guideline. Improves patient-centered care. Again, the policy and services become more aligned with the patient real needs, which leads to improved service delivery by addressing the real need. It includes kind of social, emotional, and other kind of aspect when you involve patient with the lived experience, person with the lived experience. Enhance policy and program design by incorporating the practical and emotional consideration, right? Build trust between stakeholders. So I've given you the example that how trust gets built, right? I've given you the small child example, right? Even the child did not survive, but the trust we are able to build the trust with the families, right? So this is a very, very important part. Even for the let me give you an example again here on the building trust between stakeholders. So sometimes the patient needs some kind of clinical trial because there is no other option available in the treatment, right? But when you go and ask the family or the patient that we need to get into a clinical trials or any kind of study, they are afraid. They don't want to get into the clinical trials. But clinical trials is important for any kind of treatment improvement. for future patients, right? For future treatment improvements. Then how you will build the trust between the physician or the principal investigator of that clinical trials and the patient. Of course, the patient advocacy group, we are the patient with the lived experiences can help to bridge that gap and help the physician to improve the treatment, and also help the family to understand the whole process and convince them to why the clinical trials or some kind of trials is important for their child and the future patients as well, right? So this is how the trust gets built, and ensure the policies are patient centric, not the kind of just to provide a treatment. Treatment should be a patient centric. Treatment should be patient and families should be included in the decision making of the any kind of treatment, right. Even if I take my example, I was not involved in any kind of decision making while I was getting a treatment at AIIMS. My family was not involved in any kind of decision making, right. We were asked to do certain things and we were doing that thing. But I understand that it was a long back, and that point in time it was required, and probably my doctor felt that, or the team of clinicians felt that this is important right now, and we don't need to involve the patient and the family in the treatment protocols. But now awareness has increased. People want to get involved in the decision making. People want to get involved into the all sorts of decision making in terms of medical treatment, in terms of social care and everything, right? And of course, empowers patient and survivor and family to fostering hope and resilience. It also creates a kind of awareness, empower the patients, and give them some kind of hope that childhood cancer is curable. Or in a matter of fact, in any diseases, it gives some kind of hope and empower them to be resilient and fight with the disease. Of course, I have seen that since 2006 till now, the meaningful involvement has been the pediatric oncology, especially pediatric oncology team has some kind of awareness, and they have accepted us as patient with the lived experiences, and we were part of the kind of many activities with them. And pediatric oncology space has also given an opportunity to be involved at various level, but not at the all level, but the various level. So we for the awareness kind of advocacy, now the people has given the opportunity to work on the survivorship. When I had started working on the survivorship in 2015, we had faced a lot of challenges while in survivorship. People had said that right now survivorship is not important. Why we need a separate clinic for a survivorship, right? Why? But at that point, we as a survivor, I was advocating no, I don't want to get into that crowded clinic, right? We have faced this for 3-4 years while getting the treatment. Now I want a separate clinic where doctors can pay more attention. Our OPD should be separate on separate day where only survivors can come and discuss their challenges and problems, right? But now the people has recognized that effort, and people are doing survivorship, wonderful work on the survivorship. And of course, the patient navigation and holistic care, that part has also been recognized. And some of the CanKids initiatives. So CanKids has advocated for clinical. CanKids has an initiative called PACER, which is like to create a patient advocacy group for the clinical trials, and we have done around 3-4 workshops to sensitize the PhD group about the clinical trials and all. So over 200 participants participated in that from 50 different organizations. Again, the CanKids has been doing My Rights to Care, and we are doing wonderful work on that. We are advocating for ethical framework for pediatric cancer care for better patient engagement during and after treatment. in which we are doing advocating for patient-centered care, patient and family involvement into the decision making, equitable access, ensuring all the children have access to quality care, psychological support, and survivorship care. And these are the another wonderful example of the India's two largest membership support group. One is the survivor group, another is a parent group, which has over more than 5,000 member countrywide, who do not only support each other but also provide a kind of patient navigation services in the hospital, care coordination, all those efforts. And again, the ICS is also have a survivor group. Indian Child Cancer Society has also a survivor group which is called UGAM, and these are the two India's largest survivor group. We are like kind of at holding the kind of flag for the survivorship care in India, right? And of course, there are some challenges and with challenges in involving people with the lived experiences, and this is again from my personal experiences and some of the literature. There is a lack of awareness about the value of lived experiences, limited platforms for survivors and family to share their voices, stigma and emotional barriers. Sometimes patient and the family don't want to share their emotion, and they don't want to share their journey. So that is also one stigma. And the systematic challenges in healthcare, right? And also there is an imbalance between the power transition. So that is the another barrier. Yes, and I have strategies as well, how to do effective involvement of the person with the lived experiences. So create a safer and inclusive space for sharing. Train healthcare provider to listen and collaborate with the person with the lived experiences. Involve person with the lived experiences like survivors and family in the decision-making processes at all levels, not only at the treatment level, but all levels. When you are designing any kind of study, involve that person. When you are designing any project, involve the person with the lived experiences. When you drafting any policy, involve with this person with the lived experiences, and provide support and recognition for their contribution as well, right? So that is another important aspect we need to understand. And yeah, so this is like my call to action, and together we can make a difference. So encourage stakeholders to prioritize involving persons with their lived experiences, empower persons with the lived experiences such as survivors and their family to share their stories, and advocate collaborative effort to improve childhood cancer and survivorship care. Thank you. So this is all from my end.
Thank you so much, Chandan, for your very inspiring talk. If the audience has any questions, we are happy to take it in the Q&A box, which can be read out during the panel discussion. And now we move on to our panel discussion, which will be moderated by Ms. Poonam Bagai and Ms. Aparna Mittal. They will introduce our esteemed panelists and guide us through an engaging conversation on key issues in childhood cancer care. Ms. Poonam and Ms. Aparna, over to you.
So good afternoon, everyone. So happy to be here on this celebration of International Childhood Cancer Day 2025. And as Dr. Rashmi mentioned in the beginning, this is a joint initiative worldwide by the SIOP, which is the International Association of Pediatric Oncology, and Childhood Cancer International, but something that the WHO has increasingly engaged with and supported, so that we can actually not only create awareness, honor children and families who face childhood cancer, but also advocate with our governments and other stakeholders to drive change for childhood cancer in India. We're delighted to be here for this panel discussion. And Shilpi, if you can put up the slide, that would be helpful, so we can tell you that for the next 50 minutes, we hope to engage with some key stakeholders. This is Aparna and me. Aparna, you're in Singapore, right? Aparna?
Yeah, I kind of spend time in Singapore.
Yes.
Yeah,
Aparna,
I
who's
spend
the
time between
founder.
Singapore and India.
Yes. She's the founder and CEO of Patient Engage, and I'm the founder of Can Kids Kids Can. I'm a cancer survivor myself. I'm on the ICCI Governing Council and the core operations team, and very, very proud to be part of all the work that we are doing here in India. Our panelists today, if you can just switch to the slide on the panelists, Shilpi. We have a lot of wonderful panelists. I'm sorry that we don't have Dr. Shikha Vardhan from the government, but we have Dr. Shweta Singh from WHO India. Thank you for being there, Shweta. We have Dr. Manas Kalra, our IAPPHO secretary, who's just doing some enormous amount of very, very good work for the IAPPHO now. We have Nitai from Umide as a civil society representative, Sonal as a parent representative, Sandeep as a survivor representative, and Shivani Chauhan, who's our senior program manager, ICCI, who actually does an enormous amount of work on keeping all of us on the straight and narrow and keep on working together. She makes sure we all stay at the stakeholder table. So a very warm welcome to all our panelists today. And Aparna, would you like to add something? Otherwise, we should just get into our question answer session. Aparna?
Yeah, I think we should get started. In the meantime, Shilpi, can you just check with Sandeep? I think he's not there. But yes, I think we should get started. We have a lot of, we have a very powerful panel and we've got a lot of ground to cover.
All right.
So, yeah.
Shilpi, can you put up the first slide on the roadmap? So we're discussing roadmap, right? And Aparna and I had a really interesting discussion about what we want to talk about roadmap. Our goal is to talk about a roadmap for childhood cancer service delivery in India, right? And we said, okay, what does this mean, right? Are we wanting to only talk about a strategic plan? No, we want to talk about the initiatives that we're all doing. As Raman mentioned in his deck, that these initiatives could be all over the place, which they were. We were doing many different things. IPPHO doing something, INPOC doing something, Can Kids doing something, other civil society organizations doing something. But now here we are together. And how can we actually, and we are working on a phased approach to scaling our initiatives. We also want to talk about what are prioritized actions. What are the actions we want to prioritize over the next few years as we work towards our 2030 goals. And we also discussed, and we'd like our panelists to also comment on this as we go along. We also discussed what are the outcomes that this roadmap should achieve. What is our end goal? So our end goal is we want 100% access to care by 2030. We want 100% financial protection by 2030. These are the WHO GICC goals. Dr. Vishnu, am I correct? The WHO GICC goals for universal health coverage, the international goals under the Global Initiative of Childhood Cancer, 100% access, 100% financial protection, 60% survival outcomes, and increasingly the integration of patient voice for patient-centered care. So with this background, I'm thinking that, Aparna, should I hand over to you for our first set?
Yeah. So Shilpi, can you just put on the next slide? Thanks. So I think our first question is for Dr. Manas. Given your experience with clinical practice and policy advocacy in pediatric oncology, what do you, prioritize and see as critical gaps in the current service delivery model? And how can we integrate clinical guidelines, capacity building, and research into a sustainable roadmap? And we've put the question up because it is
it's a difficult and a tricky question and a long one too. So thanks Aparna, thank you Poonam, thanks Raman for getting all of us together. Thank you ICCI. So you guys are doing a wonderful work, and we are an important part of it, and we have to play an important role in it. I acknowledge that, and rest assured our full support is there for this initiative. So, when we talk of gaps, we start with a negative connotation. So, and I have to acknowledge that, childhood cancer in India has done exceptionally well. So let's start with the positive thing, saying that we all have done very well, as we work together. And Raman showed one slide where, we had all the stakeholders and all the achievements that were there. And trust me, I'm sure he had like 100 thoughts about many other achievements that we achieved as a group, but he could not put that because there's only that much that you can put on a slide. So but we have to acknowledge at the same time that more you do, the more you realize what you have not done. So currently we are facing huge amount of gaps that are going to deter us to achieve those goals that we are targeting. And we have picked some numbers, say 60% of survival, and we want 100% access to care. But where do we get that care? How do we get to that number? We can't do that if our pediatric community, if our physician community, surgeon community is not aware that childhood cancer is a reality, which is the case in our country, because half of our patients keep getting treated for tuberculosis and typhoid for weeks and weeks and weeks, and scores of courses of antibiotics are given before they actually are suspected to have a cancer. So awareness is a very big gap, and we need to work on that. Empirical therapies is another big issue in our country. We just think that tuberculosis hi hoga, and that assumption for any child with a bone lesion, for that assumption with a child who has a vertebral lesion, any assumption like this for a child who has a lymph node, any assumption like this for a child who has a mediastinal mass, is going to put him into the risk of never reaching a cancer center on time and dying even before a diagnosis is made. So we talk of awareness, we talk of these excessive faith in empiric therapies. Then our alternative medications, alternative science that we talk about. And I don't want to criticize anything, but when we talk of such big centers for Ayurveda, such big centers for other things coming up in a big way, in one way, if the government brings in a huge Ayurvedic center and there is a cancer department in that Ayurvedic center, are we in one way endorsing that yes, there is this option that if a child has cancer, you may go to this hospital where cancer therapy may be available? So, is there a scientific basis, proven basis to treat a childhood cancer with Ayurvedic therapy? So that becomes a gap. And if that is a reality that, that is not the case, then our policy has to strongly say that. Another big gap is a referral pathway. They are not clear. People don't know where to send the patient. People don't know where to refer them, which area refers to which center. Borders are crossed. People just go by word of mouth, and they become a challenge because, you are reaching a center which is not really practical for you, for your treatment, and that leads to abandonment. So those referral pathways are not very clear. Now, when we talk of all these things, we want to give a clear direction for our childhood cancer detection and appropriate referral. And for that, we need a clear policy. We need to have clear pathways aligned with all the smaller centers, all the districts, so that patients can be diagnosed. They can be first suspected, diagnosed, or at least referred to the correct center to make a diagnosis. Now, once the patient reaches that center, we face huge gaps. You're asking me gaps in the current service delivery model. So the gaps in your particular center may be drugs, half of diagnostics. So many, I work with Poonam so closely, and we do these MCMs from such large, big centers in the country where the world is actually flocking to get treatment. And every day, Poonam, don't we discuss and question that why in such a big center we can't do a BCR-ABL testing? Why can't we give them free imatinib? Why can't we provide them, with basic asparaginase that is required to cure ALL? Why don't they have actinomycin D? Why for a basic karyotyping or FISH that is required to make the correct diagnosis and stratify leukemia, which is the commonest blood cancer in children, why do we have to take the help of 5 NGOs or say X NGO and get that test done outsourced when that big institution is actually the referral center for cancer? So, that is where we are. And at all these steps, while I acknowledge the achievements that we have made, every day is a big question to me. Why are we not able to do this? So I personally feel that we have to have a clear definition of minimum standards for everything, every child with cancer, every disease we treat. And if we have the clear definitions of minimum standards and we have our referral institutions, we can clearly point out and say, are we having all these facilities 24/7 in our institution to manage childhood cancer? And once in every state, we have identified big institution that is able to deliver your referral pathways, your shared care models, everything starts falling into place.
Thank you, Dr. Manas Kalra. I think you made some very important points in the short time you had. Poonam, over to you. It should be next slide, I think.
Question with Dr. Shweta. And Dr. Shweta, considering international best practices and WHO's global guidelines, what do you think are the key elements that can be adapted to the Indian context to improve childhood cancer care? In your view, how can the WHO support this phased roadmap that respects our local challenges in India?
Am I audible?
Yes, yes.
Okay, so thank you, Ms. Poonam, and thank you, Ms. Aparna, for this question. And first of all, I would like to thank for inviting me for this panel discussion, because this is a great initiative, which I think towards prioritizing the childhood cancer care in India. And thank you very much for your efforts. So regarding the question, I would first of all say that I think most of this WHO's global guidelines and the international best practices that have been already covered by Dr. Vishnu Giri. And based on that, the key elements that we can take up to be adopted to India context to improve the childhood cancer care. The first and foremost very important thing would be equipping our primary health cares and enhancing their capacities towards cancer detection, diagnosis, and then management, and focusing on the palliative and rehabilitative care as well. And not to forget the survivorship care as well. So PHCs hold the mainstay of all the service delivery system that is there, and enhancing them towards detection and diagnosing the cancers and managing them well for childhood cancers would be the first and foremost thing that we need to take care of. And the second, I would suggest that what Dr. Manas very well emphasized on is the referral linkages, because even after establishing, we need to, we need to mark up proper linkages with all the tertiary starting from the primary healthcare levels to the tertiary care level, where all these specialized units should be in place with all the proper infrastructure and the medicines and equipments that are there for dealing with the complications or the comorbidities or the high challenging cases. So very well defined linkages are important to strengthen our primary healthcare system as well. And both of these points will definitely help in ensuring an early detection and a prompt treatment management. Moving on to the next key element would be to have accessibility to the affordable and quality treatment services, including the medicines and the medical equipment, and focusing on the prevention, from the prevention to the patient rehabilitation as well. So, and it should be ensured that these treatment should be affordable and safe and efficient as well in context to the Indian system for the childhood cancer care. And the next point would be for financial protection that should be focused on for childhood cancer, because dealing with the patients, even for the families also, it poses a huge financial burden, and taking care of the patients, because it's a life even with the patients who are cured, it comes with various financial hardships, like losing on their wages, or like taking care of the household and the expenses of the treatments and the diagnostics, and even after treatment, care is taken care of by the family. So it poses a lot of financial hardship on the family. So financial, if uh, we can work on providing some kind of financial protection under the universal health coverage, if the government can work on it, and if some kind of health insurance, like if linking with the government sponsored schemes like Ayushman Bharat, also would help in providing that financial protection to the childhood cancer patients and their families as well. Another key element that I would like to focus on is the palliative and supportive care that needs to be strengthened, because it's not only about providing the physical relief. Palliative care and the supportive care should also focus on the psychological and the emotional distress that these patients and their families are going on, and providing them you know survivorship care. Like, it should be more based on their how they are dealing up with the disease, if they are under treatment, or even after that, even after they've got providing them with different kind of therapies and emotional support, like socially as well as psychologically. And it should be dealt with a multidisciplinary approach, like even for the families who are dealing with the patients who are dealing with the care of such childhood cancer patients, for them multidisciplinary approach, like we can think on training of these nursing cadres or some skilled healthcare medical healthcare providers who can assist these families in taking care of their patients. And the capacity building can also be taken care of, like it should be one of the important areas that should be focused. And all these paramedicals or the nursing cadre should be made aware of how to uh, you know recognize the signs and symptoms of these childhood cancers, so that they can help in early detection. And then, of course, the referral linkages will definitely help in sending those patients to the proper centers, to the specialist, where all these pediatric oncology units need to be set up, where they can be diagnosed well within time, and their proper treatment should be initiated. Apart from these, one a very important area that needs to be focused on in Indian context is the research and innovation. A lot of research and innovation is required in the field of childhood cancers, and so that the investments in these research should be uh, emphasized on, so that more and more treatment modalities and better treatment opportunities can be provided to these patients. And definitely it needs to be backed up by a good, robust health information system. And in Indian context, we have, like for other programs, we have the data recording reporting systems. For childhood cancer also, mostly we are relying on these population-based cancer registries and hospital-based cancer registries, which hardly account for 10% of the cancers which are being notified, or which are like under the data management system. So it needs to be improved, so that more evidence-based decisions could be taken up, and strategies and policies can be developed based on that. Maybe national cancer care policy can be developed based on that. Definitely, we need a good health information system in India for the childhood cancer context as well, and good government leadership is required. So there may be many points that we can work on, because when we are developing on the childhood cancer care policies, the programs, so it needs to be implemented in different ways. When a good government leadership is there, good commitment is there, then we come up with the plan, national cancer care plan, learning from the various other countries also that have already developed their national cancer plans. So it's going to go a long way if we have all these strategies marked under our roadmap. And definitely we should, last but not the least, the public-private partnerships, how we can engage the private sector for delivering these cancer care services to all the patients. And this is some kind of an area which needs to be explored further, because definitely the private sector can provide us with good expertise that is needed for maybe you can say developing the treatment regimens, or providing the better treatment services or diagnostic services to all these patients apart from the primary screening. So from the primary healthcare sectors, we need to, engage the private partners as well, working through the government to frame a comprehensive plan for all these childhood cancer services. And coming on to the next part of my question, that how WHO can support a phased roadmap. So all these definitely are the key elements, and they are India's primary healthcare system have their own challenges. How WHO can contribute to this roadmap would be to, sorry, am I audible? Yeah, there was some, okay. So how WHO can contribute is through the technical expertise for developing this roadmap. How? By providing all these evidence-based, data which is there based on the global learning or the regional learnings that we have from the best practices of various countries that they are showing us. And second thing, we can support in capacity building, definitely. The capacity building of all the healthcare providers, starting from the medical officers, the skilled nurse force as well, for providing the palliative and the supportive care, and to the program managers for implementing the program if it's there in the field. And one important point that we can help WHO can support is in advocacy, and advocacy with the government for framing this national cancer care plan, and then integrating the services. Like we have different programs already running under the government schemes, like palliative care program is there, NCD program is there. So definitely, integration, because all these are vertical programs and they need to talk with each other to have a better outcome. So WHO can support in that. And third thing is, next is monitoring and supervision. If we have a plan, definitely in the field, when you go, monitoring and supportive supervision is required, so that if a program is implemented, a roadmap is implemented, then how it is working, and based on the learnings from those supervisions, it can be further, if the gaps are encountered, those can be further improved. And of course, the knowledge sharing has to be there. Whatever data we have, data modeling, data managing. So when we have a robust health information system, when we have a real-time access to the data, then that data should be used it should be analyzed to find the gaps in the system, and where to frame these evidence-based policies. So maybe that ways WHO would be able to support towards the childhood cancer services.
Thank you. Thank you, Dr. Shweta. That was really a very, very good response, and the clarity and how WHO India and WHO Southeast Asia can help us, Southeast Asia region. In fact, Dr. Bishnu also had pointed out a lot of initiatives in his presentation, and he has shared with us that all the resources that are developed by WHO Southeast Asia region, or WHO globally, or WHO India, will be made available to the relevant stakeholders, so we can have access and learn from the best practices of other people. So both you and Manas have actually covered a lot of what we are doing. Manas, with IAP-PHO and with the ICCI task forces, we are working on developing guidelines, we're working on developing standards, and a big piece will then be to try to ensure that we are able to get people to work to those guidelines and work to those standards. And I think that's important. And similarly, we have discussed in fact, Shweta, thank you very much for discussing the entire cure-all framework, really, in terms of all the work we have to do. And I would just like to delightedly share with our audience that I think through the ICCI task forces that we've set up, one or the other group and different stakeholders in this multi-partner are actually working and focusing on much of this. And the WHO's support on this is very, very welcome. Aparna, I'll hand over to you for the next round of questions to our parent survivor reps and our civil society representatives.
Sure, thank you. So I mean, the lived experience should never be behind. So thank you for joining, Ms. Sonal Sharma. If you can share as a parent, who has navigated the challenges of childhood cancer care, what and you continue to support other parents, what do you see as the significant gaps that families experience? And what practical changes or support systems would you like to see prioritized so that families receive comprehensive care?
Parna, if I can interrupt for a second, we have 4 more speakers on the panel. And therefore, folks, may we please ask you, we have 25 minutes left of our webinar. So if you can please keep a watch on the time, or if you don't mind letting us interrupt you so that we have all 4 of your very important voices. Sonal, over to you.
Thank you, Poonam and Aparna. I would be very quick, and I think Dr. Manas made a very important and good point that, there is actually when a parent, there is no clear pathways for a parent to reach actually the hospitals, and once they reach the hospital, they are lost. And not only at times they don't understand what is the diagnosis, and when the diagnosis is made in the hospital and it is about cancer, they really don't know that what is happening to them and to their child. And at times in the tertiary center, or maybe the 4 to 5 hospital that they've visited, they might be treated for tuberculosis, and once they reach hospital, they come to know that the child had Hodgkin's or any kind of lymphoma or cancer, which now they have to get diagnosed and get treated. And often in hospital, there is no single point of contact to actually guide them through the treatment, and during the treatment and through the treatment. And at times, what the parents feel is that they are going through emotional distress, or mentally, physically, they are not able to really understand what is the proper care that has to be taken, and at times they are not even involved into the decision making while the treatment of the child is going on. So it becomes really difficult for them, and there is at times if they need to talk to understand what is the protocol, what is actually happening, how would they take care of the child, and how would the whole treatment will be how will they sail through the whole treatment. So they feel lost at the time, and they don't really have anybody to take care of them at that moment. So and financially, when they face, there is a lot of financial burden that they face. So the cost of treatment, the travel, and even the cost of accommodation and stay, there's a gap in that. So at times they really don't know that how do they go be the right person to help them in that. So what I really feel is that they not only go through the burden of the treatment and cure, they go through the financial burden, psychological burden, as well as there is a loss of the livelihood, which actually has to be actually is a big gap for them to take care. There are actually audible.
Yeah, you're audible.
So they actually
Go ahead, Sonal. Sonal, go ahead.
Am I audible?
Yes, you are audible.
Okay, so what I really feel at times is that they lose on livelihood, the child lose on childhood. There's a big gap, and at times the doctors in the hospital are more focused on the treatment than to understand the financial, physical, mental burden that the family is facing. So when we really when we are as ScanKit working into the different hospitals, and we are asking the doctors to provide when we actually are asking about the holistic care, that is the
Sonal, keep going. We can hear you.
No, audible. There's something.
Yeah, you are audible.
So what I really feel is that as a parent, So what I really feel is, as a parent, when they
Poonam, you're on silent. Sonal, go ahead. We can hear you.
I think there's some technical glitch. Chandan has gone down to sort it out. Shall we do the next question and then perhaps Sonal can circle back?
Okay.
In the interest of time, let's do the next question and perhaps Sonal can circle back once she sorted out her technical problem.
Okay.
Let's go with Sandeep as our survivor. So Sandeep, are you there?
Yeah,
Yes,
Sandeep
yes,
is
ma'am.
there.
Yes, ma'am.
Yeah,
Yes.
he's
Yes,
there.
ma'am. I'm there.
Okay.
So Sandeep, as a survivor, what do you see as the improvements in service delivery? Which improvements have had the most impact on patient outcomes, right? So this is more reflecting on what's already working, and also what you think should be included in the roadmap to improve quality and accessibility of care for newer patients.
Yeah, thank you so much, ma'am, for the opportunity. So, मैम जो सबसे बड़ा इशू जो आता है जो स्पेशली जो रूरल जो है एरियाज में जो है अर्ली डायग्नोसिस को लेकर के राइट टाइम पे राइट जो डायग्नोसिस नहीं जो मिल पाता है जो बच्चा या पेशेंट एक हॉस्पिटल से दूसरे हॉस्पिटल में जो भटकता रहता है। तो जो सबसे बड़ा जो कंपोनेंट ये है जो अभी डॉक्टर श्वेता और डॉक्टर मानस सर ने भी जो है बताया कि जो है अर्ली डायग्नोसिस एट द रिमोट एरियाज में भी जो है किस तरह से हो सके। तो उसके लिए जो है प्राइमरी हेल्थ सेंटर्स जो लेवल पे या फिर जो है कम्युनिटी हेल्थ की जो भी जो सर्विसेज हैं, जो भी जो है छोटे छोटे इलाके में जो है काम कर रहे हैं हेल्थ केयर जो प्रोफेशनल्स, उनको जो है किस तरह से ट्रेन करा जाए या उनको जो किस तरह से जो है सिम्टम्स के बारे में जो जानकारी मिल पाए, सो दैट कि जब उनके पास आता है बच्चा तो वो जो है उसी टाइम पर आइडेंटिफाई करके जो है आगे रिफर कर सकें। और जो दूसरा जो बड़ी बात जो देखने को आई है कि जो पीडियाट्रिक जो है ऑन्कोलॉजिस्ट नहीं हैं, बहुत ही जो लिमिटेड हैं। जैसे कि अगर मैं जो संत कबीर नगर उत्तर प्रदेश का एग्जांपल दूं तो वहाँ पर जो है एक भी नहीं डॉक्टर रहे हैं, उनको जाना पड़ता है, जो है लखनऊ जाना पड़ता है, वाराणसी जाना पड़ता है, इस तरह से। और अभी हाल ही में जिस तरह से जो है डे केयर के बारे में बात आई है कि जो है 100 डिस्ट्रिक्ट के ऊपर डे केयर होगा, तो वहाँ पर जो है रिमोट मॉनिटरिंग वाला जो है पॉइंट ऐड अगर हो सके कि जो है शहर से जो है डॉक्टर देख सके जो है पेशेंट्स को, या फिर जो है प्रोटोकॉल बना करके दे सकें और उनका जो केमोथेरेपी और फर्दर जो है केयर वहाँ पर हो सके। और इम्प्रूवमेंट एरियाज में हमने देखा है लास्ट जो है 16-17 सालों में जो है प्रोटोकॉल्स जो है काफ़ी आए हैं जो है, और जो है प्रोटोकॉल जो है टाटा हॉस्पिटल से निकले, बाकी हॉस्पिटल से जो है निकले हैं, और जो है सर्वाइवल रेट जो है इम्प्रूव हुआ है। तो ये सारी चीज़ें हमको लगा है जो इम्प्रूवमेंट एरिया हुई हैं। और जो साथ में ही जो काफ़ी सारे जो मेडिसिन आए हैं जो अभी उसका जो साइड इफेक्ट बहुत ही कम हुआ है। जो मेरा ट्रीटमेंट जो है 2007-8 में हुआ था, उस टाइम पर बहुत बड़ा जो है सवाल था, जो है सार्कोमा जो टाइप का कैंसर था, उसमें से 10 में से 2 बच्चे ठीक होते थे। तो अभी जो है सर्वाइवल रेट जो है 40-60 और बहुत बार जो है 80% भी देखा जा रहा है। तो ये सारे पॉइंटर्स हमारे हैं मैम, जो मैं मतलब रखना चाह रहा हूँ यहाँ पर। थैंक यू वेरी मच।
Thank you, Sandeep ji. I think Sonal, you are back. You want to speak? Sonal, are you back? No? Sonal, you want to move on to the next one? Yeah, okay, you're audible, yeah.
Aparna, let's take Nitai's question.
Yeah, go ahead, Poonam.
So Nitai, you're a civil society organization out on the East in Orissa doing some incredible work, also working a lot on community-based engagements, working with a lot of the NGOs in the Eastern sector. And so this question is not from a parent or a survivor or a beneficiary point of view, But from the point of view of a civil society organization and community-based organizations, right? How do they complement government and clinical efforts in improving childhood cancer care, right? That's one. And therefore, what is the role for advocacy, community engagement, and sustainable funding in this roadmap that we have created for service delivery? Nitai, over to you.
Thank you, ma'am. Thank you, Poonam ma'am, Aparna ma'am, and all the organizers. So, as per the question, my answer would be what I always feel: CSOs, NGOs, and civil society organizations, they are specially empowered to do a very important thing, and they are well equipped to do it in a better way. That is, bridging the gaps between all the stakeholders of childhood cancer care, what I personally feel. And it is so very important in childhood cancer care to get a, improved outcome, to engage the stakeholders like CanKids is doing in so many states, like Umeed is trying to do in Odisha. That without this, if we cannot engage all the stakeholders, we cannot listen to them, their perspective, then a good model, good workable model cannot be found out. First one. And second one, in how community-based organization or civil society organization can help to get better outcome clinically and for policies with working with government is what I feel. There are three major areas in childhood cancer care. First one is early diagnosis, maybe finding out the earliest sign and symptoms and the setting up of the referral pathways. Second one is, starting the proper treatment on time. That is very vital, and completion of the treatment properly. Third one is post-treatment perspective that leads to survivorship and end-of-life care. In all these major areas, there are several big and small service areas. And what I feel personally, what I am seeing from past several years, in almost all areas, civil society organizations are getting involved to get good outcomes. There are several examples like St. Jude, CanKids, ICS, maybe Umeed. We all are working, and when they are being involved with the doctors, healthcare providers, with the governments, the outcomes are really getting high. Let me give you some facts and some figures. In 2018, there was a data published from Pediatric Hemato-Oncology Division, AIIMS Bhubaneswar, that their initial dropout rate within the first 2 months of the treatment was 28%, and sometimes it is more. And when some credible CSOs, they got involved and worked in a very collaborative and focused way, their 2022 data was showing that it decreased to 6.20%. And if we see today's data, then it is more, encouraging. And not only this, providing, HEH facilities, providing medicines, providing resources, and many more. Now the department is so much stabilized. Now, I will go to the second section, that how CSO can be involved in advocacy, community engagement, and sustainable funding. So let me go first, as Poonam ma'am rightly said, we are very much into grassroots level community engagement. Currently, we are working in a vision called community ownership in cancer care process. So at all the district level, we are setting up our cancer information center, and we are appointing a local cancer survivor as a cancer Sahyogi. What are the major work the cancer Sahyogi is providing, working with the community? First one is actively engaging and connecting with the healthcare providers of the CSCs, community health center, the doctors, the nurses, and ASHA and Anganwadi workers, and working actively with early diagnosis and awareness of different aspects of cancer, and particularly childhood cancer. Second one, to get more and more volunteering in the community, to start a feeling of ownership that a cancer case is not the responsibility of that family, not the issue of a particular family, but it is the collective, collectively we need to handle it. Let me give you an example. When someone is being diagnosed with sarcoma, maybe the child has to go through amputation. Then have we ever think how going back to the community, getting into the mainstream, then how difficult it would be. Sometimes, children, we have seen cases, they have cornered themselves years. They are not going out to the schools and all. And this is not the issue that there are bad people at the community level. No, they are not aware. They are not known about how to handle the case. What are the small and big challenges the family is facing, and how we can deal with that collectively. So if at the community level, survivors with volunteers, they can work like a group, then this can be changed. Secondly, advocacy. I would like to give a small example how a survivor group at Bargarh district of Odisha, that is 400 kilometers away from our capital city. So they, from past, I guess 6-7 years, they had been working on proper advocacy rallies, meeting to the department people, then giving data. And currently, the government has started a proper tertiary care cancer center at that district. So this is how CSOs can engage in productive advocacy. And sustainable funding. Yes, sustainable funding. This topic, thanks to Poonam Madam, last FOSCON, she put this forward, how should be a sustainable funding and why it is very important. So sustainable funding, as we all are working, most of our organizations are knowingly, unknowingly, we are working for that. Majorly in a country, in a society like ours, where we are a population of 1.5 billion people and resources are limited, then NGO support are really life-changing to get a good outcome, supporting funding. And due to funding, I guess there are several cases of dropout, mid-treatment dropout. So sustainable funding, definitely it is always needed, and NGOs are doing very great job on these areas. And that's all from my end. Thank you.
Thank you, Nitai.
Thank you, ma'am.
Thank you. I also want to add, and Dr. Shweta, you mentioned it, and since we don't have Shikha here from the Shikha Vardhan from the government, that actually when it comes to that 100% financial protection, what the governments are doing, both the central and the state government, are doing a really good job with the financial schemes and the insurance schemes and the welfare schemes. So a lot of financial protection is actually already available. And it's easier to think of universal health coverage by 2030 with NGOs or civil society organizations filling gaps, but a large part of it being provided by the government schemes and the government insurance schemes, which we need to plug into and fill gaps. So thank you for that very, very good comprehensive answer, Nitai. Aparna, over to you for our last question for Shivani, and then maybe if we have a few minutes for Sonal to come back.
Sure. Yeah, so thank you.
Oh, sorry, one sec, Aparna. I want to put in what Dr. Manas put on our panel. He said civil society organizations are like pacemakers of beating hearts. And he also said, we can't work without you. Thank you, Secretary IAPPHO, for that very nice remark.
Right. Excellent. So Shivani, yeah, thank you for joining. And as an ICCI representative and a key member of the core operations team, who's involved in all the initiatives on a day-to-day basis, can you share some of the operational challenges you face in coordinating this multi-stakeholder activities, right? Obviously, we are all working in different directions. Some of them overlap, intersect, but I'm sure there are challenges. And from your perspective, what are the few things we can do to refine these processes so that eventually the roadmap itself is scalable and practical?
Thank you. Yeah, so since ICCI is a multi-stakeholder group, we have representations from different platforms who are working for childhood cancer. But in ICCI, most of the stakeholders are working voluntarily, where they have their own professional commitments. Like somebody is a pediatric oncologist at a hospital, somebody is a CEO of an NGO, or somebody is a practicing nurse at a hospital. So it sometimes gets a little difficult to coordinate and bring all of them together. In order to deal with this, we have 11 task forces under the umbrella of ICCI, where we have people according to their area of expertise. And to ensure that the roadmap is scalable and practical, we have the right people in the right task force. We always try and have continuous a channel of communication with all the stakeholders. And we also have a dedicated core operations team that works very closely with all of them. Thank you.
Thank you. Thank you. And Sonal, are you back on?
I'm sorry for.
No.
Okay.
You,
So
you
what
can wrap
actually I
up
wanted,
the changes
so
that
like,
you would like to see.
Yeah, so I just wanted to say, like, what we as a parent need is 100% access to the treatment and care, and at least 60% survival. Because if a child reaches the hospital, then I feel that the child or the parent have a right to be treated, and and the child should have the survival rate of at least 60% in all the hospitals. In case if there is a relapse or there's a problem, then there is somebody to be talking of the relapse, because we are not even talking of the relapse and making them understand what they will go through, and what is actually the mental and physical trauma that a parent and a child go through a relapse. Then when we say of holistic care, at times we are talking of treatment, diagnosis, and care. We are not talking of holistic care, because it is important not only, of course, it is important first, it is very, very important to get the treatment and the cure, but after that, what is required is, because the child loses on school, who's there to at least make sure that there's a teacher or there's somebody to guide them, there is a psychologist, there's a dietitian. So the holistic care is what I think is the requirement of the parent and a family during the time of treatment. So if we pay emphasis to the holistic care during the treatment, I think that will help a parent and a family to not only to fight through cancer and to understand and to reintegrate back into the society.
Thank you. Thank you so much, Sonal, for highlighting the challenges that families face in navigation, and what kind of support would be required, and not just for medical care, but the other aspects of care as well. Are there any audience questions that we just have about 5 minutes, I think. So is any audience question?
Poonam, can I make
Yes.
a comment?
Sure.
Yes, Dr. Manas.
So Poonam, I was really hoping that we'll have some senior government officials, and I'm sure you guys, Raman, everybody made their best attempt to have them, but unfortunately we could not. But I just want to say this, and Raman is listening to me.
Can I also request actually the speakers to join us, in this final segment? So Dr. Raman and Dr. Vishnu Giri.
Shweta and Dr. Vishnu, I think, left eventually. Yeah. But Dr. Shweta is with us. Raman is with us. Yes. Manas.
What I want to say is that, Poonam, if you look at government and government's will to participate, you see rare disease policy. If you all look at the rare disease policy, these are extremely rare conditions that are most of the times not even diagnosed. Okay? Every child with rare disease, government is willing to spend 50 lakh rupees per child. There is a commitment, clear commitment for the rare disease policy. If you have a child with a rare syndrome, if you have a child with a rare disease which requires a bone marrow transplant, you have a rare disease, metabolic disease, which requires liver transplant, you have a rare disease requiring a kidney transplant, lifelong continuation of some metabolic therapy or anything like that, tyrosinemia, name a rare disease, the government is committing 50 lakh rupees for every patient. So that's the government's will to do for children with difficult disorders. So I'm pretty sure that the government has the will to do it for childhood cancer as well. It is just that all the, people sitting on that table that Raman pointed out, unless we all go together, make a noise for this and plead and beg and, fight for our cause, we are not going to get it. And ICCI and all the stakeholders here, I think we have to find a way that we represent ourselves in such a strong way that we get what we need for our children.
So, Manas, thank you for the point that you've made. And I think that is exactly the purpose of what we're doing at ICCI. At the end of the day, I can tell you that when we launched the Say No to Financial Pain last September, and we had Niti Aayog member health at the launch as our keynote speaker, he said, come back with what you want because your numbers are not so huge that we can't make that difference. And I think what we are doing when we talk about a roadmap and what we have achieved, and Raman showed what we are doing as stakeholders, is sort of pulling together what we need to have so that we can go to the government with the asks. Now, the government may not, unlike in other countries that Dr. Bishnu pointed out, they may not be ready to give you a full-fledged national plan policy. But I think, and Raman would agree with me, they're positive about come with exactly what you want. I can tell you, working in the state governments where we have not come across a single state government that says we won't do it. They're committed to the idea. They're waiting. How will you bring it together? What do you want? Do you want that? Then they're not outlaying huge amounts of money, as you said, 50 lakh rupees a child. But I can tell you that the member health did say that when you come back for CAR-T with numbers, facts, and figures, CAR-T, no less, we can talk about it, right? So it's up to us. I think it's important that we put it together. We have data, which I think is something that we're building up quite nicely. And we have numbers and figures. And with that, when we go back to the government with our asks, I do not think that we will have that much trouble, right? And so I think what Raman highlighted in terms of all the task forces and what they're doing, what Sonal highlighted in terms of these are the priorities that we should be working at, what Nitai talked about, we have all the ingredients. And I'm hoping that, in the next 1 year, we should be able to go back to the government with the same kind of ask that the rare disease community went with. Raman, would you like to add to that?
Yeah, no, I put a comment there just to save time, which essentially echoes what you're saying, that our response has been encouraging, and we were pleasantly surprised. And I think it's not for want of their interest. I think the way policy is made, you've got to interact with them at different levels. And so if you only come down from top, but have not done the groundwork, then it is not a good recipe for a successful execution of a policy. If you're only working on the bottom and you don't hit it on the top, then you will never take it off the ground. And so it's just getting it right. And also the point which Manas makes about these rare diseases, and I'm very happy that the parents of these children will get access to this, which is very valuable. And I don't know a lot about this, but we know that the money is only one part of the puzzle. The money is not going to buy them early diagnosis, or the money is not going to get them good communication, and so on and so on. So I think as a community, we also have to have all the other ingredients together, which when combined with, financial support, etc., would make a good mixture. Thank you.
I think it's important to make the case. And I think in order to make the case, you have to do a lot of homework. I think a lot of people within the community and the task forces, ICCI, IAPPHO, INPOG, the civil, we are all doing our homework. And sometimes before you go to the government, you have to have your homework, right? I think, therefore, it's exciting that we are where we are. Yes, Dr. Shweta, thank you for making the point that strong data-driven advocacy is important for plausible solutions. So more than a policy, we need to work on actually data-driven advocacy, which is what I think we will be doing as we move forward. What's important today as we celebrate ICCD, International Childhood Cancer Day, is, the theme, which is about not just, we know the challenges, we've been addressing the challenges, we are now working at the solutions, and how, when we need the government, we present our solutions to the government for answers from the government. Right, Dr. Shweta? And in turn, we also do our own work to try to improve service delivery as different stakeholders within the community. Dr. Shweta, since you made a very good point, it would be lovely for you to wind up our discussion. It's always good to have WHO wind up a discussion for us.
Thank you, Ms. Poonam, for giving up this opportunity to me for concluding this discussion. It was a really very wonderful discussion with all very prominent points that have come up, like with the CSO's contribution and with what kind of advocacy we need here, the data that is required to drive the policy decisions, and of course the rare diseases remark. That is a very well said point, that if that could be done, then definitely this can also be done. And it all depends upon how we advocated with the government to bring that commitment, that required commitment into the government's policies and all the programs that they start up with it. So thank you everyone for this wonderful discussion, and I hope to take this further to achieve the results that we are looking up to. Thank you. Over to you, Ms. Poonam.
So thank you, Aparna. I think it's been fun moderating with you. I think thank you all the panelists for participating. So lovely, wonderful. Dr. Rashmi, back to you.
Yeah. Thank you. Thanks, Ms. Poonam. And you and Aparna did a great job. Wonderful questions. As we conclude these insightful discussions, I extend my heartfelt gratitude to all our distinguished speakers, panelists, and also the attendees for their valuable contributions. It's very evident from all these conversations that by working together, that's us healthcare professionals, government, civil society, survivor communities, we can build a stronger and more effective framework for childhood cancer care in India. We encourage everyone to stay connected, specifically with ICCI, and continue engaging in meaningful conversations that can drive change. Thank you all once again for your participation. Looking forward to furthering this mission together. We extend our gratitude to ICCI for their leadership in organizing this event. Ms. Aparna from Patients Engaged for her invaluable support in making this discussion possible. CanKids, Ms. Poonam, Ms. Sonal, and others at CanKids like Ms. Nirbai for their excellent ideas in conducting this meeting. And last but not the least, a special thanks to Shilpi Chauhan. She's the project coordinator at ICCI for her dedicated coordination and efforts in making this event a success. She's actually a star backstage. So wishing you all a great evening ahead. Bye.
Yes. Thank you. Thank you, Shilpi. Thank you, the team at ICCI.
Thank you. Thank you, everyone.